Will introduce. Good afternoon, everybody, and welcome to the webinar. I am Andrea Baer, the Executive Director here at Mended Hearts, and we are so excited to have you join us today. While everybody is jumping on, I want to give you all just a few tidbits of information before we get started. All attendees are in listen-only mode. If you cannot hear, hopefully you can read the slides. Check the audio button on your personal computer to assure the sound is on. Please type your questions into the Q&A box at the bottom of your screen anytime during the presentation, and the moderator will read your questions during the question and answer period. Please note that the presenter may not be able to answer specific health questions because they're not your attending physician. The PDF version of the slides, as well as a recording of this presentation, will be available on the Mended Hearts website following the event. And handouts, if there are any, will be available as well on the website. So, as I mentioned before, I am Andrea Baer, the Executive Director here at Mended Hearts. With me, I have Jody Smith, the National Program Director for Mended Hearts, and we will be moderating this session. Mended Hearts is a national community-based nonprofit organization, and our mission is to inspire hope and improve the quality of life of heart patients and their families through ongoing peer-to-peer support, education, and advocacy. And we're very excited today to present how to manage your heart device with confidence. And with that, we have an amazing speaker with us, Dr. Harish Manyam. He specializes in cardiology and cardiac electrophysiology. He serves as the Chief of Cardiology, Director of Cardiovascular Research, and head of the Atrial Fibrillation Center at Erlanger. He is actively involved with multiple research trials, including monitoring the reoccurrence of atrial fibrillation, optimizing programming options in patients with biventricular defibrillators, and the assessment of lead extraction risk. Dr. Manyam, thank you for being here with us today. I am going to allow you to grab the screen so that you can share your slides.
Okay, can you see my screen?
Not yet.
Okay.
There we go. Now we see you.
Okay, can you see my video?
We cannot see your video, but we can hear you and we can see your slides.
Okay. For some reason, it's not enabling starting the video. Yep. Sorry, so you can see my screen.
Yes, and we can hear you fine.
Okay,
Sadly, we
so
don't get to see your face, but that's okay.
okay, well, I'll just go ahead and get started. I'm sorry about that.
That's okay, thank you.
Welcome. So, all right, well, thank you all for joining. My name is Dr. Harish Manyam. I'm the Chief of Cardiology, Director of Cardiovascular Research. And I was first asked to give this talk, and I was just really enthused by the fact that we were going to have a talk talking directly to patients, patient advocates, about really cardiac implantable devices and how you take care of them. And not only how you take care of them, but how do you take care of your family members? How do you take care of your neighbors? And how do we assess potential issues? And one of the issues that goes very unrecognized are cardiac device infections. And so if you just imagine that there's a device in your body and that it could be potentially infected and needing some kind of further care, but that infection may go under-recognized or undertreated, can lead to dying. And so like to just get started. And I guess if there's any questions, we would get it in the chat box.
Yes, that's correct. And we will read them out to you, so you won't have to worry about the chat box at all.
Okay, fantastic. Well, most people think about devices as, these kinds of devices. So these are just appliances, obviously. And you get appliances at home, and obviously they work and you expect them to work and you never expect them to be a problem. And usually they're not. But in some cases, we have things go bad and you have to call an appliance repairman and someone comes out and fixes things. And we expect that that usually doesn't happen. And when it does happen, we get a new device. When we think about cardiac implantable devices, very different, right? We're putting a device into someone's body. And so this is just an x-ray of a device. And what you see here, which I think everyone can see my mouse, is that you see this cardiac implantable device. And what this is called a defibrillator, okay? And a defibrillator is a device with wires that can go into the heart. There are defibrillators that don't, and I'll show you some pictures of both. But these are wires that are going into the heart and they actually track through a vessel into the heart. And so this is great, but the reality of this is most people don't know what's actually in their body. And so this is actually an inverted image looking at an x-ray and subtracting kind of the light area here and then showing you the dark parts of it. And you can see the wires a little bit better. And so here you have the defibrillator here, and there's multiple wires here. And there's actually more wires in here than most people would see. And these are all the different kinds of wires that are in the heart. And so the interesting thing about this is that most people don't need this many wires in their body. However, this patient just happened to have more wires than they needed and some wires that were left behind because someone thought that they would be fine there. And this patient came and actually we needed to fix some of the wires. And the wires are made very differently, just like appliances. Sometimes we think about one appliance over another for a feature, and wires and defibrillators can be chosen based on different features and how they're made. And these wires are made in different ways. But just like any mechanical object, these objects can fail. And if they fail, then in some cases they need to be replaced or repaired or taken out and fixed. And so this is just a semblance of what could be in someone's body. So we think about devices and why we put them in this picture over to the right of your screen. It's kind of the classic case of someone passing out. And so from the 1800s, people have passed out and before then, and passing out spells can be anything. They can be, very benign where people have lightheaded spells, dizzy, they feel sweaty, and then they go down, which naturally in most cases we think is a benign actual episode. And in some cases, people pass out suddenly. And this is not the picture you would see of someone who passed out suddenly. What you would see is someone laying on the ground, in some cases, having multiple contusions, bruises, in some cases being in car accidents. And the reason is because they have abnormal heart rhythms. And so abnormal heart rhythms, or as we refer to them as arrhythmias, in some cases can be very slow heart rhythms, and in some cases can be very fast heart rhythms. Both of those kinds of rhythms, in a lot of cases, need cardiac implantable devices to actually improve the chance of someone living and actually improve the chance that they will live longer. And so the real question is if these devices can help us live longer and actually make us feel better, then how do we keep them working? So these are the devices. We have different devices called loop recorders and devices called pacemakers and other devices called defibrillators. So loop recorders are small little devices. They go underneath the skin. They're about the size of a pen clip. If you imagine a pen that you put in your pocket and that clip that sits in your pocket, they can automatically transmit information. So in a lot of cases, we put these in for patients who have abnormal episodes where they pass out, or in a lot of cases more recently, patients who have had strokes and we're looking for abnormal heart rhythms. They're very, very common now and actually growing significantly in the world in the sense that in the past, when we had these little monitors, it required a much more invasive procedure. And now it's very, very simple to put in. and easy to transmit, and the information is very good, that there's a bigger demand and market for them. And so we will continue to see a lot of those. And this is what they look like. It was actually the last one that came out is from Abbott, and it's a small device, just, like a paper clip almost, and was named one of Time's best innovations of the year. And so pacemakers look like this. It's much easier for us as doctors to have people tattooed with a pacemaker sign over their chest, but we don't require that. But this is what a pacemaker actually would look like. And so the device actually looks fairly small, roughly about the size of a $50, with a wire that actually is put into a port in the pacemaker. And that wire actually tracks into the heart to actually deliver an electrical impulse to control the speed at which the heart can beat. And so in general, we use those for patients who have slow heartbeats. And so when heartbeat is that slow, we put this in to make sure that the heartbeat is regulated. And we think that usually anywhere from 60 to 100 beats per minute is a normal heart rate. So we generally set these pacemakers at a base rate or a lower rate of 60 beats per minute. So patients get a pacemaker and then come to us and have a normal heartbeat. And we have defibrillators. So defibrillators are bigger. They're roughly the size, usually about half size of an iPhone almost. So you have the relationship between me holding a defibrillator and Apple phone in my hand. The defibrillators, interestingly enough, can also be used as a pacemaker. So commonly I'm asked, am I putting a pacemaker in also? And actually now it depends, because defibrillators do different things than pacemakers. And so the one on the top where you see here actually ports in it, and these ports attach to wires, and those wires go into the body, and they can deliver electrical impulses that can use, similar to a pacemaker, to regulate the heartbeat, either fast or slow, but in some cases also deliver to the heart if the heart goes into a dangerous heart rhythm that requires that. We also have defibrillators now that actually look like this, and the defibrillator actually sits right outside of the rib cage, but underneath the skin, and the wire does not actually go into the heart. It actually sits underneath the skin and is tracked underneath the skin like this. And so the defibrillator can shock the heart, but in this case, since there's no wire that's actually touching the heart, the wire cannot actually deliver an electrical impulse, and therefore cannot regulate slow heartbeat. So it cannot be used as a pacemaker. So how do we implant these devices? We actually, in most cases, pacemakers and defibrillators are put pretty close to your collarbone. And so in general, we give people good sleepy medication. So they're in somewhat, this la la land kind of feeling. We make a small incision, usually underneath the collarbone, and track wires from a vessel here through a vein into the heart. And then depending upon what kind of pacemaker or defibrillator they need, put 1, 2, or 3 wires into the heart to deliver the electrical stimulation that we require. And so when we put these devices in, similar to anything that we have that's electronic in nature, appliances or phones, we need to think about potential issues. And so the issues that we generally look for are the battery. And so these devices have batteries in them. There has been some research in the fair remote past about using devices that were kinetic in nature. The issue with that is if for some reason the heart were to stop and then you actually needed the pacemaker to work, there's a chance it may not work because there's no feedback loop. And so it does require a battery. The batteries in most patients for pacemakers last 7 to 10 years. For defibrillators on average, could be a regular defibrillator, could be anywhere also to 7 years. And then special defibrillators, which also require a high amount of pacing, which are called biventricular defibrillators, usually on average 4 to 6 years. And so when we watch patients over time, we watch for this battery depletion. So we have checks that we can do at home, checks where patients come to the office, where we actually monitor for battery depletion. In addition to that, we look for lead failure. So we're making sure that the wires are actually working appropriately, because if the wires seem like they start breaking in some kind of way, either the outer coating goes bad or the inner wire that actually conducts the electrical sensation to the heart goes bad, then that lead would be impending failure, and we would want to replace that with a new wire. And that's part of our checking the device over time. And the other thing we need to watch for is an infection. In most cases, we can see infections pretty soon after a device is implanted, which are usually local infections, meaning we see some redness at the skin. And long term, or even right after the procedure, we can see systemic or infections that affect the whole body, and those are bloodborne. That's because these wires are traversed through veins and actually go into the heart. So the infection that may start at a pacemaker or defibrillator site can actually track down these wires into the heart and cause systemic or infections throughout the body. So battery depletion, when we do see battery depletion, we just go in and replace a battery, and it's usually in and out procedure. Patients go home the same day, and it's usually nothing for patients to worry about. When we watch for lead failure, some of the things that we can see is that the insulation, as you see in this picture, the actual outer coating of the insulation can go bad, and we get these wires that are actually supposed to stay inside actually come out of the lead itself and be exposed and not function appropriately. And you can see this here under X-ray where the wire is kind of coming outside of the insulation or outside the encasing of the lead itself. And this can happen actually up to 20% of the time over the course of a patient's life. And so that's pretty high. And so there's a good reason for us to continuously monitor these devices as time goes on. And the last thing, which it's maybe the most important thing because it's something that it's very important for patients, their family members to notice. And so you can see redness at the site of a pacemaker. In some cases, they have what's called a wound dehiscence, where the wound, the pacemaker area or the defibrillator area, the wound comes apart, which could also be a sign of infection. And in some cases where we see a systemic infection affecting the whole body, then we actually see bacteria in the blood. And so you may be actually, or someone you know, may actually be admitted to a hospital, be diagnosed with bacteria in the blood. In some cases, we call that sepsis. Some cases, they may say that's bacteremia. And those words are all the same in a lot of ways, but means that there's some kind of bacteria in the blood. And when patients have pacemakers or defibrillators, it puts them at a high risk that either the pacemaker or defibrillator may be infected as well. And if you can imagine that these wires are actually in the heart, and also in the heart is blood circulating. And especially if there's bacteria in that blood circulating throughout the heart, then that bacteria can form on the leads and get on the leads and actually continue that infection regardless of antibiotics that we can deliver. And so this is what an infection can actually look like, is that we can actually have this kind of infection, which just kind of looks red here at the left side of the screen. And then over time, if that doesn't heal, we can get what's called a wound dehiscence, where the wound just opens up. And this is a serious case where actually the infection went on for way too long, and the pacemaker actually started making its way out of the skin. And so how do we treat these infections? Obviously, we can use antibiotics. But in addition to using antibiotics, we have to remove the pacemaker, and also we have to remove the wires that are in the heart. And this is a very safe procedure. And in most cases, this is what we should be doing. It's not always done because there's not everybody who does this procedure available, but this is called a lead extraction. And what we're doing here is actually removing a wire that is infected from the body. And this is actually called a lead extraction using a spectranetics laser. And we use this laser to gently remove tissue that may have grown, just fibrous tissue that has grown on the wires, and keeping those wires adhere to the heart so the wires don't move in your body very much once they're in there for a period of time. And so this device uses laser to actually remove that tissue so we can remove the wire from the heart. And so why should we take these leads out, and in what cases would we use this laser technology? We would use it for different reasons, but obviously if there's a malfunction of the lead, where we saw in that case where the coating has gone bad, in some cases we want to use special wires that in some cases have not been put in, and we want to put those wires in, and we take out a wire and put a new wire in. In other cases, we're trying to add a wire, and what we find is that there's no actual vessel left there, and you get these collateral blood vessels that form underneath the skin. In some cases, people can see that near their pacemaker, that they see blood vessels, kind of like a spider almost. And that's usually because there's an occlusion there. Generally, that's nothing to worry about because we have blood vessel that comes from the other side that can actually drain blood appropriately into the heart. However, if you're trying to add wires into the heart, then there's no actual passageway for wires to be tracked in there. Other reasons to add, or I would say subtract, extract wires from the heart are, in some cases, patients don't have MRI safe pacemakers. And so for the lifetime of the patient, they're unable to have an MRI because they have these pacemakers that are antiquated. And then what we saw in one of the first pictures that I showed on the screen, which was that inverted X-ray, we saw multiple wires in the heart. So here in this picture, you see 1, 2, 3 top chamber wires and 1, 2, 3 bottom chamber wires. And that's a little bit excessive and unneeded in the sense where someone had unnecessarily wires into the heart where they should have taken out faulty wires to begin with. And so we think about reasons to take out these devices and wires, and these are important reasons. And we think about infection. It's really, we call it class 1 indication, which is something very, very important from a medical standpoint, meaning that something that we absolutely should do. And so when we see a local infection, which is really important, even that redness of the skin where we think the pacemaker is infected, not only does that pacemaker itself need to come out, the wire that's attached to that pacemaker and then traverses down to the heart also needs to come out. And the reason that needs to come out is because that bacteria can actually go from the pacemaker in that pocket that it's in and actually traverse down the leads into the heart and then cause that systemic or widespread infection and cause really severe illness in people, and some cases cause death. So we want to be really cognizant of recognizing infections and treating them early on to prevent morbidity or mortality. And there are other reasons why we would take out these leads. So some people have severe pain at the site of their infection, as we showed a picture where there's an occlusion of the blood vessel, the wires themselves are broken, or we need MRI capability, or we have lots of wires in there that just should not be in there. And so we think about, to focus really on this infection, 65% of patients who have infections really are not treated appropriately. And part of the reason is there's still this standpoint for physicians, doctors, to sometimes see an infection and say, oh, it's a skin infection, and maybe just to treat it with some antibiotics so the skin infection goes away. The problem that's sometimes under-recognized is that this is not just a skin infection, that it's actually an infection that's much deeper. And not only is it deeper past the skin level, that because that wire traverses into the bloodstream, that it likely will cause a bloodstream infection. And so we find it very, very important to treat these patients. And so as we see a lot of those patients that have infections, 41% of them actually have infections that actually go into the bloodstream. And that's why a lot of people think these are only just in the pocket where the pacemaker is, but 41% actually can cause this systemic infection. And so when we think about what the real risk is, when we think about when patients have an infection and the chance of dying is just having that local infection that we talked about is 1.7%. Taking out the wire is much lower than that. And so it's much safer to take out the wire than do nothing. And that risk only goes up as that infection spreads from that pocket into the systemic vasculature. And then in addition to that, if it spreads into systemic and someone has diabetes, their rates of dying are much higher. In addition to that, if someone has kidney failure, then their rates of dying are extraordinarily high. And so we want to be really cognizant of looking at the patients who have local infections very early so we can prevent the chance of them getting worse and dying over time. The other thing that we've seen is advisory leads. There are wires that go into the heart that sometimes don't work appropriately. And unfortunately, it's just like a car, that a car could be on the market for a period of 2 to 3 to 4 to 7 years. And eventually they find that certain things are failing in the car over a period of time, and they issue a recall. And very similarly, some wires have had recalls on them where we've then noticed that these wires are faulty. We've submitted them to a database, the database gets analyzed, and over time, there's so many reports of a certain wire that we decide that all of those wires should not be put in anymore. And once they're in, unfortunately, those wires have a chance of failing that are fairly high. These are just different wires that have been put in. And over time, what their rates of failure are, and they're fairly high. And so we aim to take those out when we see them. The other thing that we've seen very commonly is these wires that are left behind. And so when we see patients who have multiple wires in their heart, the problem is that when you leave a wire behind, that wire that you leave behind and you add a wire next to it, you may leave it behind because that wire is broken. So you put a new wire next. Well, the problem is that that wire that's broken is now a pretty old wire. So if you put in 3 years ago and now it's you're putting in a new wire, 6 years from now, that wire will be 9 years old. And so the older the wire is, the harder it is for us to get out. And the more wires that are in the heart, the higher risk of infection. There's a higher risk of actually causing also leaking of the heart valve because we have to traverse some of these wires through a heart valve and actually into certain areas of the heart. And then in addition, if you can imagine two of these wires, that are in the same location, that they can actually rub against each other. And by rubbing against each other, they can wear each other out and actually cause failure of the wire. And so there are multiple reasons why we don't want to just leave these wires behind. And so when we look at multiple studies that have looked at the safety of just taking these wires out, they've all shown that the study just over time in a lot of patients, the risk of just really, we call it procedural mortality, the chance of dying is very, very low. And we find that very important to note because we know that the risk of dying by not doing anything is very high, especially with infections. And so we know that there's factors also associated with success. And so the younger the wire, meaning the wire is not super old, then it's very easy to take out. It's also important that the person taking out the wire has done a lot of these kinds of procedures. That's pretty common with all procedures. We also know that in certain patients, that there's just a higher chance, like we talked about, if they're infected or if they have diabetes or they have kidney failure, that the chance of them dying with this disease is much higher with those risk factors. And this just goes along with what we think the procedural mortality should be, what the acceptable range really is, and really what our real mortality is much lower than what our acceptable and perceived mortality should be in these procedures. And when we think about procedure rates, because sometimes it's important to understand when I get a common procedure, what is the chance of me dying from that procedure and what's the chance of me dying from this procedure. And so we just put up this comparative rate because a lot of people have, heart catheterization where they have to have a stent. And so the chance of having a chance of dying from that is anywhere from 1 to 2%. Chance of having risks from that procedure is 4 to 5%. Also a common procedure called an AFib ablation, where chance of patient dying is extraordinarily low, but the chance of having potential risks are in the 5.9%. And when you think about lead removal, in reference to that, the having any risks are 1.4%, but then the chance of dying, again, 0.28% there. And so just as a summary here, I think it's very, very important to follow up with your heart doctor, especially with these kinds of devices, specifically with an electrical heart doctor, what we call an electrophysiologist. And whenever you have something that you feel uncomfortable, it's always good to go see someone, go seek an expert. And if you see someone and you feel uncomfortable, go see someone else. And it's always important to be, and I always reference this to all my patients, that they are the captains of their ship and I am their guide. And if they don't like their guide, they're always allowed to kick me off their ship. But it's important for them to understand as much of their health I understand about their health. And so they feel like they can be their own advocates when they go into a room, or they have a question, or they have some knowledge as to what's going on with them, especially when they go somewhere else. And that's all I had. I just want to welcome everyone once again, and just if there's any questions, I'd be happy to answer those.
So it looks like we have a bunch of questions. So
Yeah.
really,
Okay.
Hey, Jody and Mandy, would you moderate those questions for us? Because we have a lot.
yes. And so there's some in the chat box that Mandy's going to look at, and I'm going to start with one, and Mandy and I will switch off back and forth. I'll start with one in the Q&A, and that is from Sam, and he says, can these wires or leads sometimes remain in our bodies if an implanted device has been removed?
Yeah, this is a great question. Thanks so much, Sam, for your question. And obviously, what you went through is very, very difficult. Having a heart transplant and having a defibrillator taken out at the time, very, very difficult. In most cases, when they do heart transplants, they remove any wires. So if you imagine prior to your transplant, what they probably had was a defibrillator in. And then when they actually do a heart transplant, they explant the heart and they remove the defibrillator. And so they remove the defibrillator from your chest, take the wires out that are there. But when they put a new heart in, it's very typical for them to put on temporary pacing wires outside of your heart. And that's usually with any open heart surgery. Those wires are usually temporary in nature, and they usually, in some cases, cut them at the skin. So there's some remnant wires outside of your heart. And that's a little bit different from this. Those wires don't cause you a risk of an infection because they sit outside your heart. In most cases, they do not pull them. And the reason they don't pull them, if this is the same wire that we're referencing, is that it can sometimes cause bleeding on the outside of the heart sac, especially after you've had open heart surgery. There's nowhere for that blood to go. So it kind of goes into this, kind of chest wall. It can cause major bleeding. So they kind of leave them alone. And that would be reasonable. I don't know if that answers your question. I'm happy to hear a follow-up question if I didn't answer that.
Thank you, Dr. Manyam. This is Mandy, and I've got a question from the chat box. Darlene asks, she currently has a CRTD device. Will her heart improve, or I guess could anyone's heart improve, not just hers, enough that she will no longer need it?
Yeah, that's a great question, Darlene. Definitely, I'm a huge advocate for CRTs. I'm involved in lots of trials, and then we have actually, I think, 9 active trials with CRT devices. Most patients that we put in CRTDs, what the numbers I kind of give them is that 70% of patients who get those kinds of defibrillators, they improve. Of the rest of them, 30%, 20% of them improve not just a little bit, they improve a lot of it. So we call them super responders, and 10% of them do not improve. Okay. And so those are the, I would say, overall numbers. And those are pretty old numbers, but probably the best numbers we have to really tell people how they're going to get better. I would tell you that it is based on them putting a CRTD, definitely the best chance of you improving from a heart failure standpoint. Usually what tends to happen is that your breathing and your ability to exert yourself gets better. And in some cases, and I really want to say some cases because that's what most people want, right? Is that in some cases, especially if you've not had a heart attack before, that's important. Some cases where you have not had a heart attack before, the heart function can go back to normal. So it's a really good thing. These devices are great.
Okay, so I have another question from the Q&A, and that is, if the patient is athletic, is the pacemaker battery being subject to more work? Would the battery be depleted sooner than 7 to 10 years?
Fantastic question. So it's actually no. So you can be actually very athletic. I've never seen a pacemaker break except once where someone damaged their pacemaker because they were an MMA fighter and someone hit their pacemaker and actually bent it. You could see it underneath the skin. But being athletic doesn't necessarily mean that your pacemaker battery will go bad earlier. But actually the use of the pacemaker or the use of a defibrillator, the more it needs to be used, the more the battery will be drained. So that's important. So in your case, if you have a pacemaker and it was put in for what we call complete heart block, meaning that there's completely no transmission of electrical signal normally from your top in your body chamber, and you're dependent on the pacemaker, it works all the time normally, then that pacemaker will drain faster than someone who only uses it intermittently, but they both need pacemakers.
Question from the chat box. Bonnie asks, how are lead failures typically discovered?
Great question, Bonnie. So, that's in most cases, we discover that by monitoring patients. And so there's a pretty standardized way that most people in the country monitor their patients. And so once we put in the device is actually checked, obviously, at the time we put it in, checked the following day, and then checked in follow-up. And the follow-up schedule is usually, within 1 to 2 weeks after the device is put in to make sure the wound is okay. And then every 3 months from then on. And so at those 3-month intervals, what most people do is one of those 3-month checks is done from your home, and the subsequent 3-month check is done in the office. And we can detect those lead failures through either of those transmissions most of the time. And by detecting that, then we would take further action, let you know, and then go from there.
So the next question, actually, there are 2 questions from Ron, and he asked, do wires always go to the right side of the heart, and is MRI not allowed when you have an ICD?
Great questions, Ron. So wires in most cases go to the right side of the heart. So you think about a pacemaker, and I didn't talk about wireless pacemakers, but pacemakers in general go to the right side of the heart. So the right atrium and the right ventricle, if we have wires in both chambers on the right side of our heart. These CRT devices, which one of the panelists asked, and another panelist talked about this biventricular Icd that they have, that device actually has wires on the right side of the heart and actually has a wire that goes to the left side of the heart. And the wire that goes to the left side of the heart is tracked through a vein, and that vein happens to sit on the right side of the heart. So it's actually interesting. We track that wire from the right side of the heart into the left side of the heart, but it's using and pacing from the left side of the heart. So it's actually a very interesting concept. Can you tell me the second part of the question again? It was the MRI. I got it.
Yeah.
And so defibrillators, yes, absolutely. Defibrillators and pacemakers and loop recorders can all be MRI safe. And so all of these devices at this point have the capability of being MRI safe, but the reality is within the last 5 years is when the transition happened. And so if you've had a pacemaker or defibrillator that has not happened in the last 2 years, if it's older than 2 years, then there's a chance that it may not be MRI safe. The other thing is that if you've had wires that are much older, then those wires themselves may not be MRI safe. So even if someone puts in a new device into your body and that device is MRI safe, the problem is the wires that were originally put in may not be MRI safe. And so they all have the capability of being MRI safe though at this point.
Okay. We've got a quick question here asking, are you put out for battery replacements?
Good question. And so the answer is maybe. It depends on who your doctor is. For what we do here is we do put people, we give them, I call them like, martinis or, like just a little bit of sedation where you're in this la la land kind of thing. Most people are talking, but they don't have an awareness as to what we're doing. And so I think people feel very comfortable. There's a good reason why we do that and don't put people deep to sleep. Most people who have devices may have slow heart rhythms or weak heart muscles. And when we're changing out these batteries, we don't want to subject the patient to deeper anesthetics if we don't have to, because that also slows down the heart rate. And in changing out these devices, we have to detach a pacemaker and then attach the wires to a temporary electric source so we can deliver energy as needed and then attach it to a new battery. And so we want to make sure that the heart rate that you can have during that procedure can be adequate. So you'll be comfortable, but not usually in most cases put completely out.
So the next question is by Bonnie. If a lead and or defibrillator is taken out due to infection, are they replaced after the infection is treated?
Fantastic question. So we do that. And so it's kind of a if, and but. So if you have an infection and we have to take out the device, we obviously take out the device and the wires. The and is, and if you have an infection and you require permanent pacing, meaning you're dependent on a pacemaker, then we have to put a temporary / permanent pacemaker in for a period of time. Usually that's done through the neck or the leg, and you'd have to stay in the hospital where there's some kind of pacing source outside of your body and a wire that's going into your heart. And we clear the infection with antibiotics, and once it's cleared, reimplant a new device while you're in the hospital. Now, in most cases, we would prefer not to do that. What we would prefer to do is, take out the device, let the body completely heal. And if it's an infection that's actually infected the whole body, then in some cases, most cases actually, you need 4 to 6 weeks of antibiotics. And so we'd like to implant the device after that period of time.
I've got 2 questions and I just lost my chat box, sorry. It's one of them is there a time frame that most infections occur, or is it through the whole lifetime of the device? And then the second is, what are the key questions I should be asking my heart doctor during my visit with them? What questions about my device?
Great questions. So I'll start with the first one. I hope everyone can see this chat box. I think I have it pulled here too, but the time frame can be really any time. And the reason why, I think most likely you can have infections right after the procedure. So it's very important to keep the wound very dry after the procedure. Listen to your doctor's instructions, be very, very vigilant about that. But even long term, we're all at risk of potentially developing an infection. And it's, if we think about really the biggest organ of our body is our skin. And so the skin is the barrier to the outside world. We're all living in this coronavirus, standpoint, and skin does help protect us from a lot of organisms. And when there's a break in your skin, there's a potential risk of having a bloodborne bacteria. And so that bloodborne bacteria gets in, it's able to infect lots of areas of the body, including your bloodstream. And once it affects the bloodstream, then it can affect the pacemaker. So it's something that we have to be cognizant of lifetime. But I would tell you that if you do have a pacemaker defibrillator and you do develop something called sepsis, your doctor tells you that, or your doctor tells you you have bacteria growing in your blood and you have a pacemaker, you should ask, does something need to be done about the pacemaker? And it's important to push that as a question, because some people may or may not know, but infectious disease doctors, electrical heart doctors know generally the right answer. And so those are usually people that you should look to and try to figure out if you're looking for an expert in those kinds of situations. The second question, what are the key questions I should be asking my heart doctor? What questions about my device? So when you go in and you have a device, if you have a pacemaker, really just making sure you talk to your doctor about your symptoms. Most people, after I put in a pacemaker, feel much better. I mean, they notice a significant difference in their life, and that's important. And so that's something people generally see. If you have a pacemaker and you start feeling like you're more short of breath with walking, you feel dizzy, lightheaded, something feels different, right? Where you didn't feel that before, that's something that you need to let them know, because it may be something with your device. Obviously, if you see any redness around your device, fluctuance or kind of puffiness around your device, those are things that you need to let them know at any moment. And so if you see that at home and your doctor's visit is in 3 months, do not wait for those 3 months to wait to go see your doctor. You call their office and let them know that you need someone to look at your pacemaker site. And that takes us 30 seconds to do to make an evaluation, okay? So it's not that hard to do for people to just come in, take a look at it. It looks good, right? There's some reassurance level in there. In general, I think it's very, and I don't know if the first question was meant to be extraordinarily general about your heart doctor, but I think it's an important question. Make sure that you have a good communication and clear stream with your physician, because I think that's important. If you can't communicate to the person that's sitting across with you, or you don't feel like there's a good stream, then it's important to have someone who can hear what you're saying, understand what you're going through, and walk you through it. And so I think those are important factors of it. And so I think just making sure that you talk about your symptoms and things that are going on with you, and the devices, kind of the location of the pacemaker, and if anything's wrong.
So I think that probably goes with Craig's question about how important it is for the patient to ask if after the procedure, if any wires were left behind. But I don't know if you want to touch on that a little more specifically.
Yeah, I think that's an important question. I think in most people, if you're getting a pacemaker for the first time, that's generally not something you should have to worry about. I mean, they're putting in new wires, they're putting a new pacemaker in. But if any time, a doctor or someone tells you, yeah, you have a broken wire, I'm just going to go repair it, that's a red herring. Instead of taking it out and putting a new wire in, or I'm going to put a new wire in. And then the question that you should be thinking about is, well, should I take out the broken wire? And there should be a discussion. In some cases, there may be a reason why your physician says, look, your risk level with everything else combined is so high that they feel it's unsafe. But in most cases, it can be done fairly safely. And I think that always, to talk to someone who does it as part of their normal day-to-day routine, it's important to go see someone who does that, and then to make sure that it's taken out.
Okay, my questions are kind of combined. Bonnie asks, how is it decided between a Crtd device and an Icd? And then Fredonia asks, what is the difference between those two?
That's a great question. So, so just the difference between a Crtd and an Icd. So a Crtd, if we think about it, is really also called a cardiac resynchronization therapy device, defibrillator, okay? Crtd also, the other word for it is called biventricular defibrillator. So the first picture that I put on the screen, there was multiple wires, but the wires have wires on the right side of the heart, and they have a wire on the left side of the heart. And I really wish my video was on, because I could be Italian, I think. But what you can see when you put a Crtd in, and the reason why we put it in is that we want to see a re-coordination of the heart muscle, and we put it in because patient's electrical system is taking too long to transmit electrical energy. So the heart, instead of acting at the same time from both sides, one side of the heart beats first, and then after that heart actually relaxes, the other side of the heart beats at that time. And so the heart's actually not in sync. And so when we see that from an electrical standpoint, which is just an EKG, we recognize that a Crtd or a biventricular defibrillator is what that patient would need. Whereas a defibrillator also functions like a CRTD in that it could be a pacemaker and it can actually shock the heart, but it does not pace both sides of the heart. And the reason why we put that in versus the other one is that the patient who gets an ICD alone and not the CRTD, they don't have this electrical delay in their heart that we see on an EKG. And so there would be no benefit to add that third wire.
So the next question is by Richard. Do you recommend removal and replacement of leads that are non-MRI compatible with ones that are compatible, even though there are no current problems with them?
Say it one more time. Sorry, my thing just broke up for a second.
That's okay. So if someone had leads that are non-MRI compatible, should they get them replaced even though they're not having any problems with them?
Gotcha. Yep. So that's a great question. I would say the answer to that is no. You should get something done if you need it done. And so if there's some people who have spinal injuries, back problems, need further evaluation. They can't get their CAT scan. They can't get a myelogram, which is not just really that diagnostic in comparison to an MRI. And there's got to be a discussion then at that point where, I'm trying to get further down the road because my hip is an issue, or I'm having severe back pain and the doctors can't figure out why. And they think I need an MRI and I can't get an MRI because of this device. That's a good reason for us to do something about it. And so I think if you have this device that's old and, for whatever reason, you have that and you don't need an MRI, then I'm not sure that you should necessarily just take out the wires. There's more and more data coming out that some of those devices, we can try to figure out an MRI that may work for them in a safe manner. And we just have to be cognizant, though, of the potential risks in that. So I would say that if you're fine and you don't need an MRI, then don't do it. I think if there's a reason to do it, then the question is, can we do it with the wires that are in there in an MRI safe environment that would be reasonable? Or should we take out the wires and put a whole new system in?
Okay, Sam's got a couple questions, and Jody, I think this is answering one of the ones in his Q&A as well. So can a device be implanted and connected to a transplanted heart if needed? Does that ever happen? And then are children implanted with CRTDs ever? And then there's an X-ray security, airport security. Are they safe for those?
These are just, all of you guys, I just want to reiterate, these are fantastic questions. I love doing this. So the answer to the first question is yes, a device can be implanted, connected to a transplanted heart. There definitely is sometimes needs for that. It's generally not because the heart muscle gets weaker. In general, in some cases, because of where the connection is to the transplanted heart, sometimes the normal conduction system of that transplanted heart does not work appropriately. And so in some cases, people need pacemakers going forward. It's not extraordinarily common, but it's definitely possible. And so we could definitely, in the future, need to have to put a pacemaker in. Can you repeat the second and third question?
The second question was, can children be implanted with the CRTDs? And then the other question was, what is are these devices safe and leads airport and X-ray safe?
Great, thanks so much. Yeah, so absolutely, children can be placed actually with the same devices that adults have. The only difference between a child and an adult in a lot of these conditions is the size. And so I also do pediatric work. And so I've implanted devices into children. It's much more rare and uncommon, but definitely possible. X-rays, you can get X-rays with device, obviously. Showed some pictures of these X-rays with these devices. They're definitely safe. Now, when you go through the airport, they have obviously different metal detectors and newer detectors, where if you've gone through the airport, where you put your hands above your head, and they're called millimeter wave detectors. And so metal detectors, we recommend that patients don't go through because there's a chance of a resetting functioning happening in the pacemaker or defibrillator. So you should notify TSA that you actually have a pacemaker or a defibrillator. And what they would generally do is pull you to the side, wand you, and then have you go around. The other detector, which is called a millimeter wave detector, it's where you raise your hands above your head. those are generally thought to be very safe. They don't interact with the device, and you can go through them without an issue.
Sorry, I was trying to unmute myself. So one question is, how many infections can be treated with antibiotics before a removal is necessary, and why do doctors abandon leads?
Yeah, so in general, I don't abandon any leads, but I would tell you for a fact, I've seen leads that have been abandoned over a period of time, and I think people think it's a very inappropriately think it's a very risky procedure and portray it sometimes to patients in that manner, but it's not. Just based on the data, it's not a risky procedure. It does need to be done by someone who does them routinely, and so that's very similar to what I would say about anything we do. I mean, I don't go get my car. I don't change my oil in my car because I don't know what I'm doing. But I do feel very comfortable in taking out people's leads. And so that's why you have experts in these fields to do those things. In general, antibiotics should be used for any of these infections, and specifically long-term, it's something that could be used continuously, but they shouldn't be used forever. In some cases, they are because someone is nearing their own end of life, and we're concerned about what our value is in adding to that. And if we're putting them at any risk in doing a procedure where they're just trying to potentially maybe just live 3 months or 4 months, and they have metastatic cancer, and we've seen things like that where they also have an infection, then in some cases treating them with lifelong antibiotics is not unreasonable.
This is a really excellent question, actually, for women. One of our attendees said this morning she had a mammogram, and the tech attempted to include her ICD in the 3D picture, which was painful. How can she guide the tech the next time?
Yeah, it's a great question. It's very painful, to have your device really moved around during a mammogram. It's one of the most common complaints I have from women when they have their mammograms. It's very important to tell your tech that you have a device. In most cases, the devices should be right underneath the clavicle to avoid your breast tissue. I have seen devices that are fairly low, and especially if you've had a replacement from a pacemaker or defibrillator, those devices can get very low where they actually get into breast tissue. And that becomes the problem, is that this device is in the breast tissue or very close to the breast tissue, where the tech does need to actually get into the breast tissue and look at the breast tissue to make sure there's not a sign of malignancy. And they want to make sure that if there's they can see what they need to see. And so I guess the first part of it is, if as long as your device is not in the breast tissue, very important just to tell the tech that even if it is nearing your breast tissue or in the breast tissue, it's important to let the tech know there's a device there. Just be cognizant of it. It causes pain, but unfortunately, with mammograms, they do have to press fairly hard to make sure that they can see things.
So the next question is, how is it decided whether you get a CRT or an ICD, especially for people with low ejection fractions?
Yeah, great question. It's very similar, the question that we just had, where the Crtd versus an ICD, but the Crtd is the one, and the way we make the distinction is a Crtd is the one where you have 3 wires and the third wire goes to the left side of the heart. That's where it resynchronizes the heart, gets it back together, where there's an electrical delay that we can see on an EKG, usually called a bundle branch block. And an ICD, both of them we put in for a low ejection fraction or a low heart function. But an ICD, we put it in and we recognize there's no electrical delay, there's no bundle branch block. Therefore, there's no need for that third wire that goes to the left side of the heart.
All right, I think that we are reaching our end of time together. I think there are a ton of other questions, but I want to be cognizant of everybody's time, and I appreciate you being here with us for the hour. The other questions that we have, we will get you some answers, and we appreciate you being patient with us. What a fantastic webinar and so much great information, and we really appreciate you being here with us. So I want to thank you again, Dr. Manyam, for being here, and to everyone listening, thank you for taking an hour out of your day to learn about this really important topic. We appreciate it, and we look forward to our next webinar in our Stay in Care series, so stay tuned. Thank you all very much.
Thank you.